Hello everyone, we are now going to go over the peripheral blood flow cytometry from a 27-year-old man who presented with pancytopenia and circulating bilobe blasts with occasional auras. Let's start with CD45 versus site scatter. We see that almost everything in this plot is in the blast gate, and the blast gate is defined by a dim CD45 expression and low site scatter usually. But here we see that the cells that are painted red that are sitting in the blast gate kind of have a very high site scatter. They're kind of going all the way up. Although we restricted our gate till here, we could see that the population is going all the way up. Now let's trace this and see what it expresses. And in this scattergram, we see that they are negative for CD34. They have a bright CD33 expression. They have a partial 117 expression. They're negative for HLA-DR. They are partially positive for CD15. They express CD38 and they express CD13, partial 11B. They're negative for CD14 and CD64. So far we see that they express myeloid markers. One interesting thing we saw that is it is negative for CD34 and HLA-DR. And the myeloid markers that it expresses are CD117, CD13, very bright, 1333, and it expresses partial 11B. And monocytic markers 14 and 64 are negative. There is a partial 15 expression. And everything else pretty much is negative. It is negative for 16, 56, 3, 7 T cell markers, 2, negative for 4, negative for 8. It is negative for CD71. It is negative for the B cell markers 19, 20, and 10. And this is a cytoplasmic tube, and it shows that in here it expresses very bright cytoplasmic MPO. It's negative for CD19. So I want to first tell you what this is and then discuss the phenotype so that you better understand. This is an acute promyelocytic leukemia. So in one Friday fine afternoon, you're ready to leave at 4:30 p.m. You suddenly get a call from the oncologist, and then you rush your smear review and flow cytometer, and this is what you get. So acute promyelocytic leukemias, they usually present with pancytopenia, and the WBC count is usually low. And when you see the blasts that are abnormal promyelocytes, are also called blasts, these have very high site scatter because the highest amount of granules in the granulocytic lineage is in the promyelocytes. So they have very high site scatter. Sometimes some people say it looks like troll hair in this plot of CD45 versus site scatter, like hair standing up and going all the way up to the roof of the site scatter. And these are negative for CD34. So if you remember the myeloid maturation, promyelocytes come after the myeloid blast stage, right? So these blasts are kind of somewhat mature and they got arrested at the promyelocyte stage. So they don't have 34 anymore because they are mature than the CD34 positive myeloid blasts. And therefore they are already expressing bright CD33 and CD13. And they have lost HLA-DR again because they have matured to the promyelocyte stage, and they express 117, and they're actually in the process of losing it also. And if you see, if you remember, myelocyte stage starts gaining 11B. So promyelocytes usually are not negative for 11B, but then they can start acquiring 11B and CD15, and they're positive for CD38. CD64 again can be positive in some of the myeloid precursors, so you can have a bit of CD64 or partial CD64 expression in APLs also. But other markers are usually negative. So this is a classic acute promyelocytic leukemia. And also, if you remember, the granules are positive for myeloperoxidase, so they also express the brightest myeloperoxidase in the cytoplasmic tubes. So to summarize, APLs, CD45 versus site scatter is a huge clue. The 45 versus site scatter will show the blasts having very high site scatter, and they are negative for CD34. Ideally, like classic APLs are negative for CD34. They have bright CD33 expression, they are negative for HLA-DR. So when you see this combination, you should think about APL, and other markers can be variable. 13 expression can be partial, 117 can be partial, 64, 11B, 15, they can be there, they need not be there. CD2 expression can be seen. So all these are variable, but high side scatter, bright CD33, negative HLA-DR is pretty consistent. So when you see this, you have to alert your clinician right away, and you have to do FISH studies for APL and for T1517. And again, here you don't need 20% blast, and there is usually never a problem in identifying, in getting the numbers in these cases. But you have to rush the clinician because they have to start ATRA on these patients because there is a risk for DIC. So one thing that you have to remember is similar phenotype can be seen in NPM1 and FLT3 mutated AMLs, but those usually do not have very high site scatter, and they have low site scatter, and they might have some monocytic markers also. And your morphology helps. APL will have biloblasts, they can have RRODs if you're lucky. And then your NPM1 and FLT3 mutated AMLs usually have the fish stoma or cup-shaped blasts, and that helps, and low site scatter helps. But otherwise, when you see this phenotype, immediately alert your clinician and rush your FISH studies. When you sign these out, you can sign out as AML, highly suspicious for acute promyelocytic leukemia. Obviously, you cannot call it promyelocytic leukemia just by flow. You need translocation 15-17 for that. So this is how you sign out. Thank you.